All right, so we'll go through the patient journey for acute cholecystitis. What symptoms do they have, Jeanette? What do they come in with? Constipation?
No,
not really.
They come in with right upper quadrant pain,
Yep.
sometimes epigastric,
Yep,
sometimes a bit of reflux,
yep,
nausea, vomiting, could be bilious in nature,
yep.
sometimes fevers depending on how far along they are,
Yep. Anything else?
sometimes
Yeah.
diarrhea,
Maybe. I guess sometimes they could have a touch of steatorrhea. Anything else? Multicolour.
Sometimes the nature of the pain can be quite suggestive of it.
Yeah, what's the nature of it?
So often can be around food, so after ingesting food.
Postprandial. Good.
Intermittent in nature.
colic,
Oh, depends how you define, biliary colic, but sort of, I guess. It's not like an intestinal colic, though, is it? No.
And can it radiate to the back? Can it be quite
Yeah, can radiate to the back. Radiation to the back. What signs do they have, Mel?
They will be tended to not go on abdo-out.
Yeah.
To the
What about suprapubic?
Suprapubic.
Yeah. None?
Oh, right up the
Right at the front, okay, good. Anything else about the exam?
They might have inflamed, will increase inflammatory markers.
Yes. White count, CRP.
There could be a degree of jaundice.
Yeah. Jaundice is probably more, you've got to think about a biliary obstruction rather than just inflammation of the gallbladder. But yeah, jaundice is associated with biliary presentation. And anything special about the tenderness in the right upper quadrant, Clark?
So you might be suggestive of like if you can get underneath the liver and feel like the.
What's peritonism? What's a eponymous name for peritonism in the right upper quadrant? Murphy's, yeah. And how do you do Murphy's?
You get the patient to breathe in and out, and tenderness should occur on respiration.
Yeah.
Right.
And if you wanted to do a negative control for that, how do you do that? Just do it on the left. So you're going to take a big breath in and out on the left and see if it also catches it. So Murphy's sign. What other tests do we do, Kat? Sorry, Danny?
we can conduct imaging.
Yeah, what type of imaging?
Well, preferably then up with the CT abdo.
Yeah. More commonly though, we do ultrasound. And what are the findings on ultrasound we're looking for? Mel? Yeah, so thick wall. Very cholecystic fluid. How thick's the wall?
More than 3
Yeah, greater than 3 mil. Very polycystic fluid. What else on the ultrasound?
Let's see the presence of calculi
Yep.
and whether they're
Exactly.
mobile
Yeah,
or not.
calculi, because what's the cause? Is it stones? Is it acalculus? And pretty important one.
Oh, and
Yeah, look, I'll talk about duct and whether the stone's in the duct. But there's another important one for diagnosis of
General
acute
staff
cholecystitis.
transfers complete.
Would that be a distended gallbladder?
Yeah, that helps, I guess. Yeah, big wall, distended gallbladder.
Oh, plus a sonographic.
Yeah, a sonographic Murphy. So they can stick the probe exactly over the gallbladder and go and push on it and see whether they turn. So a sonographic Murphy is very important. Okay. So once you've got all that, you can figure out whether or not they've got acute cholecystitis or whether or not you're totally off the wrong path and they actually have, a peptic ulcer or pancreatitis or something like that. And to make sure you don't have, some other condition, you do a lipase and amylase. very commonly, someone with acute cholecystitis will have normal or close to normal LFTs, and a normal amylase lipase. And then if they've got abnormal amylase or lipase, then you've got to think pancreatitis. If they've got, significantly abnormal LFTs, you've got to think about a stone in a duct in addition to just inflammation of the gallbladder. So, so you figured out, through a combination of signs and symptoms, you've got your differential, and you've decided that it's acute cholecystitis and not one of the other causes. What do you do about it? Who we up to? Jose.
Okay, so
So the patient's got acute cholecystitis. What are we going to do?
we need to, well, first of all, ensure that the patient is admitted under a surgical bed.
Yeah.
And ensure that there's DVT prophylaxis if it is staying.
Yeah.
Furthermore, you try and give some prophylactic antibiotics or an IV
Prophylactic antibiotics?
in case it goes into cholecystitis type issue.
Yeah.
Like a treatment dose of antibiotics.
Yeah. I mean, yeah, look, a lot of the times you're right, acute cholecystitis is a chemical cholecystitis rather than an actual bacterial infection. But it's often hard to tell. I mean, the biliary tract communicates with the GI tract, so yeah, a lot of acute cholecystitis will have a bacterial element. And so antibiotic guidelines generally say to treat it. And what do you treat it with? Mel?
No, next.
Yeah, look, I give metronidazole. Antibiotic guidelines say ampicillin and a gram negative, so usually Gen, unless they're contraindicated to Gen. And then it gets a little bit indefinite. It sort of says, if they've had multiple episodes, give metronidazole. If it looks complicated, give metronidazole. By that you can sort of, if it's really a mild case, or potentially even an outpatient management case, you can give, Augmentin Joe Fort or Ampin-Gen, but if it looks complicated, or if you're otherwise worried, add metronidazole to the regime. And obviously if you've got allergies, you've got to adjust it accordingly. So you've given the antibiotics, what do you do now?
Well, I suppose you split it up quite nicely. You need to work out whether they're acutely unwell or whether they're, stable. So the idea would be, either if they're really acutely unwell, they're going to need theatre or surgical intervention,
Yeah.
as well as antibiotics. So that you need to fast them. You need to.
So how many are well and how many are unwell?
I imagine that this right upper quadrant pain related to cholecystitis is pretty common, so I'd say maybe 60 to 70% would be well.
Yeah, I'm guesstimating, but I reckon it's from like 80 to 95%.
Yeah.
I'll define what I think what well means anyway, and unwell is the rest. So why do you make that differentiation, well, unwell?
I think because it would tell you how quickly you need to expedite surgical intervention.
Yeah.
And also the other treatments that you might need to be getting anaesthetics involved, ICU involved,
Yeah.
those sorts of things.
I'm just going to jump the gun and just move on straight on to surgical management.
Yeah.
Like in my day, it was quite important because most people got sent home. Most people were managed non-operatively and sent home for an elective operation. It's less important now because even the well ones, we're doing them on their index presentation rather than sending them home for an elective operation. So I define the unwell as the ones who really look sick and you worry about, a complicated acute cholecystitis presentation. And the two things I'm worried about are an empyema or acute necrosis where, the gallbladder's black and dead. And, they look toxic and septic and, you really shouldn't be trying non-antibiotic, non-surgical options for those. They need to go to theatre and probably fairly quickly. And they make up a very small percentage, probably only 5%. So in my day, you had to recognise those and not give them conservative management. These days, even most of these people get a operation on their index admission. But at least even in this day and age, you have the option to give them choice, okay? And depending on their anaesthetic issues, it may well be more appropriate to treat with antibiotics. So that's why we used to make that differentiation, and that's why that differentiation remains relevant today. So Jeanette was asking, when do we do a hot gallbladder and when do we try to settle it down? I sort of have a limit of 7 days, so you're right, it gets sticky after 3 or 4 days, but it's sort of potentially manageable up to 7 days. Certainly after 7 days, provided they don't fit this category, you probably try to settle it down with antibiotics and then get them back electively. So in the bad old days when most people were treated electively, treated non-operatively with antibiotics and waited for their gallbladder to be done electively, how many of those would have got acute cholecystitis again in the 3-month wait period between sending them home and their elective operation?
Fairly high proportion, I imagine.
Yeah.
3%.
What number? Any percentage in anyone's mind? Jeanette?
Say speak for 30.
Yeah, about 30%, 1/3 represented acutely, and took up another another ED presentation. That combined, I know the experience in Wagga is often when they came in electively, sometimes they get bumped by a more urgent case. So more and more, particularly with the ASU service, we treat them on their index presentation. What we don't treat, or what we still send home, is biliary colic. And when you put all this together, what makes a biliary colic and what makes an acute cholecystitis?
So biliary colic, from what I understand,
It's sort of,
gives you the right upper quadrant pain, you
Yeah.
have these symptoms,
Yeah.
but they come and go over a long period of time.
yeah.
Whereas it seems that acute cholecystitis is the duration of symptoms lasts for longer and doesn't abate without treatment at all.
Yeah, look, things I would say this patient's got acute cholecystitis are, Murphy's, either ultrasonography or, ideally sonographically. If they've got a fever, a white count, and if they've got pain for more than 24 hours, that's acute cholecystitis. If they don't have a white count, they're afebrile, they've just got the pain, the Murphy's might be very, very mild or they're just tender, and the ultrasound just says they've got gallstones and there's no thick wall, then they have biliary colic, and they probably really can be sent home and done electively, and their risk of representation is probably quite low. And then you give them a certain amount of patient choice, and some want to go home, and but some might want to insist that they be treated by the ASU and operated by the ASU, so the problem doesn't come back. So they get their operation. The operation involves taking the gallbladder out, doing an X-ray, which involves injecting dye, cannulating the duct, injecting dye down here to see if there are any stones, and then treating the stones appropriately if possible. What are we worried about? What do we look for on day 1, Danny?
Post-op.
Yeah.
Fevers.
Yeah, fevers. What else does a surgical reg look for on day 1, Mel? What do you look for, Jeanette?
Pain out of proportion to normal post-op expectation.
Yeah.
Bile
Let's
and
assume they're
anti-drain.
okay.
If they have a
Bile and anti-drains.
Bile and drain. So we look for bile in the drain, we look at the wounds. And you make sure they eat and drink, they're not up and about, hopefully their pain's a bit better. They're going to get a little bit of wound pain, but hopefully you can get them home after that. I'll just talk a little bit about the consent for a lap chole. What's the main complication we need to consent for? Anyone except for the registrars know.
One would be an open procedure, so if you plan
Yeah,
like it's got to be open. The other might be if there's you could cause pancreatitis,
Not really.
major bleeding.
Mildly.
Not really. Yeah. There's a catastrophic complication that we have to consider.
Cutting of the hepatic duct.
Yeah, or the common bile duct. So significantly damaging this thing. And it looks great on the pictures. You know, how could you miss that? But when things are stuck down and glued together, you know, the gallbladder might be stuck to this might be up here, the duct might be short. So the rate I give is 1 in 300 chance of a major duct injury. And why is that a disaster?
Well, first of all, you're going to have to reoperate it.
Yeah.
But also, you're going to get biliary leak into the intra-abdominal space. And
Well, the main thing is your first thing. I mean, you can control the biliary leak and all that sort of stuff, but you need a big operation. You know, you need to connect these little ducts here to distal to where you've damaged the common bile duct, and that's a big 6-hour operation. Sometimes it has to be done in a unit in some other hospital. And when you do that, they potentially get, complications all their life. They get cholangitis easily. So that's a major complication. A complication they need specifically to know that, in addition to all the other risks, bleeding, infection, GA, wound, that's specific to this operation. Any other questions, queries, worries, anything else you want to know about the patient journey? I think we've hit 15 minutes. Yeah, so often look for bile in the drain, the usual post-op stuff. The reg will give you an indication of how long to give antibiotics for. If the acute cholecystitis was well treated, the guidelines tend to say you don't really have to give antibiotics for many days, if at all. And then the usual post-op stuff. No heavy lifting for 6 weeks, keep the wounds clean, go back to work in 2 weeks. Anything else I've missed?
Sorry,
Doctor?
you've talked about cholecystitis.
I haven't, no. If they've got really bad comorbidities, you don't think they'll survive a GA, and you can just put a percutaneous tube through the liver into the gallbladder and let the bad stuff drain outside. That's a cholecystostomy tube. We don't do that commonly. But that's so that there's a seal. So the problem, like, if a surgeon did it laparoscopically, they'd probably stick a tube in here, and there's probably going to be some bile leak outside that. So to reduce the bile leak into the peritoneal cavity, the radiologist goes through the liver, drain the gallbladder. Yeah. All right. No. So Clark asks a really good question. What happens if there's a stone in the common bile duct? Either diagnosed beforehand on your ultrasound or intraoperatively. If you know about it beforehand, you can do an ERCP, and Dr. Harrison does that, and he can whip the stone out. Alternatively, if you only find it in the middle of your operation, you can put a stent down, and that allows for drainage until a definitive ERCP can be done. Or alternatively, you can try to explore the duct through the cystic duct using a basket or a balloon and fish the stone out that way. If it's a bigger stone, you have the option of laparoscopically cutting into the duct and fishing the stone out that way, or converting to an open procedure and exploring the duct that way. So they're the options you have to get stones out. Yeah. Just something about consent. 8% of people get reflux after their operation, and sometimes that's good to let them know of as well. anecdotally, some people get an improvement of their reflux as well.